Hello students. So the topic is calcium homeostasis. So in this topic we will see how this calcium is maintained normal in the body. So why the calcium should be maintained normally in the body and what are the hormones that are acting to control to maintain this calcium level and what are the organs involved in maintaining this calcium level. So first we will see a case. So then you will know why the calcium should be maintained. What is the importance of maintaining this calcium level normally in our body? So this is a case 1. So here 41-year-old man with the parathyroid adenoma who presented to emergency department critically unwell with a serum calcium of 6.1 millimole per liter. He suffered a ventricular fibrillation arrest. The ECG shows very short QT interval and J wave in lead 4. So this is a case. So here they have given a serum calcium level 6.1 millimole per liter. So you should know what is the normal calcium level. So millimoles means 2.5 millimoles per liter is the normal. Okay. So and ventricular fibrillation. So what is the finding in ECG? Short QT interval and J wave in lead 4. So 2.5 millimoles per liter means, so that means the serum calcium level is increased in this case. So what is this? This is a case of, yes, this is a case of hypercalcemia. So hypercalcemia means increased calcium level. So this is the ECG, see in the lead 4. So see the arrow, that is a J wave. So what are the ECG changes in hypercalcemia? The main ECG abnormalities in hypercalcemia is shortening of QT interval, Osborn wave, that is J wave, ventricular fibrillation, ventricular irritability. So this is a case of hypercalcemia. Yes. What is this one? Identify this picture. Yes. So this is a carpopedal spasm. Carpopedal spasm. So this is a case of hypocalcemic tetany. So hypocalcemic tetany means when the calcium level goes below the normal level, that is called hypocalcemia, where you will get the spasm. Okay. So this is called hypocalcemic tetany. Hypocalcemic tetany in the hand called carpopedal spasm. Yes. Come to the physiological importance of calcium. See, the calcium plays many key physiological processes in the body. So we will see one by one. First, structural integrity of bone and teeth. So this calcium is essential for bone formation, that is mineralization of bone. Then blood coagulation. You know the calcium is a coagulation factor 4. So and this is very essential for clotting of blood. So it plays a very important role in blood coagulation. Enzymatic regulation. So this calcium, it is involved in enzymatic regulation, means it modulates various enzyme activities. So the enzymes use the calcium as a cofactor. So enzymatic regulation. And then release of hormones and neurotransmitters. You know there is a process, calcium mediated exocytosis. So in transport classes you have learned, no? So that is exocytosis. So release of the hormones. So secretion of endocrine exocrine glands. So through calcium mediated exocytosis cause release of hormones and enzymes from the gland. So that is one. And neurotransmitters, acetylcholine release at neuromuscular junction. The nerve excitability. So normal extracellular fluid calcium concentration is essential for neural membrane stability and resting membrane potential. And also, what's the next one? Muscle contraction. So for genesis and maintenance of action potential, especially in cardiac muscle and smooth muscle, this calcium is essential. And you know, for the pacemaker potential, in various pacemaker tissue, this calcium is essential. And also the excitation contraction coupling during muscle contraction, where the calcium plays important role. And this calcium acts as a second or third messenger in various intracellular signaling pathways for hormone action. So like that, this calcium plays a many role in a normal functioning of the body. Yes. Yes, the calcium, if you take the total body content of the calcium, see it is 1000 grams. So if there is 1000 gram of calcium is in the body, so in the 1000 grams, 99% will be present in the bone, and 1% in the intracellularly and 0.1% extracellularly. So 1000 grams வந்து 99% is present in the bone, 1% intracellularly and 0.1% in the extracellularly. So what is the normal serum calcium? It is 10 milligrams per deciliter. So if you take a range 9 to 11 milligram per deciliter. So average is 10 milligram per deciliter, and milli equivalents it is 5 milli equivalent per liter, and millimoles it is 2.5 millimoles per liter. So this is the calcium 1000 grams la வந்து where it will be present. So come to distribution of calcium in the plasma. So you have two forms, diffusible form and non-diffusible form. So diffusible form, you have the ionized form of calcium. So diffusible means it can diffuse. Ionized form, complex to anions like bicarbonate and citrate. Non-diffusible means protein bound. The protein bonds are called non-diffusible. So this total diffusible la வந்து ionized will be 50%. 50% of the calcium will be in the ionized form, and complex to the bicarbonate citrate anions na வந்து 9%, and non-diffusible protein bound is 41%. So in this 50%, the ionized form is a form that is most important for the functions of the body. This ionized calcium is the biologically active form. So that form plays an important role for the normal functioning of the body. Ionized calcium. So that is the biologically active form. So the same distribution. So ionized is 50%, protein bound is 41%, and calcium complex to anion is 9%. Yes. Coming to the calcium exchange. So how the calcium is exchanged between the different tissue compartments. So what is the intake, how much is excreted through feces, how much is excreted through urine, so how much is exchanged between the bone and the extracellular fluid. So we will see that one. See in this picture the calcium intake 1000 milligram per day. So the usual rate of intake are about 1000 milligram per day. So intake is 1000 milligram per day, and so in this intake 35% of the ingested calcium is usually absorbed. So see, absorption 350 milligram per day. So that is 35%. 1000 35% is 350 milligram per day is absorbed, and the remaining, how much remaining will be excreted in the feces. So 1000 350 na வந்து remaining is 650, plus in additional 250 milligram per day of calcium enters the intestine via the secreted gastrointestinal juice and sloughed mucosa. So see, 250 is secreted into the intestine. So the gastrointestinal juice and the sloughing mucosa, all that contribute to 250 milligram per day of calcium. So 650, remaining 650 plus the secreted amount 250 together form 950 milligram per day of calcium. That is 90%. So 90% of the daily intake of calcium is excreted in the feces. So 350, that is 35% of ingested calcium is usually absorbed. So next is, we'll see the renal excretion of calcium. So renal excretion, 10% of the ingested calcium is excreted in the urine. So 10% means 100 milligram per day. 100 milligram per day is excreted. So you know the distribution. So the 100% la வந்து 50% is ionized, 41 is bound to protein, and 9% is bound to the anions, okay, such as citrate, phosphate, and bicarbonate, that one. So in this 41%, which is the non-diffusible, that is protein bound form, will not be filtered by the glomerular capillaries. So the protein bound to plasma proteins will not be filtered by the glomerular capillaries. The rest one, which is combined with anions and the ionized one, is filtered through the glomerular capillaries into the renal tubules. So protein bound is not filtered, remaining is filtered through the glomerular capillaries into the renal tubules. See, normally in the renal tubules, the 99% of the filtered calcium is reabsorbed. So only the 10%, 100 milligram per day, are excreted in the urine. So 99% of the filtered calcium is reabsorbed. So in that 90% of the calcium will be reabsorbed in the proximal tubule, loop of Henle and early distal tubule. See, remember in the filtered calcium 99% will be reabsorbed. 19% will be reabsorbed. Okay, so in the 99% la வந்து 90% of the calcium will be reabsorbed in the proximal tubule, loop of Henle and early distal tubule. And the remaining 10% will be reabsorbed in the late distal tubule and early collecting duct. So this is very important here. This 10% will be depending on the calcium ion concentration in the blood. So depending upon the calcium ion concentration, this 10% will be reabsorbed. Okay. So in the distal tubule, that is late distal tubule and early collecting duct, so depending upon the calcium concentration is reabsorbed. So when the calcium concentration is low, the reabsorption will be more. So almost no calcium is lost in the urine. And this portion of this reabsorption is controlled by PTH, the parathyroid hormone. So the parathyroid hormone controls the amount of calcium reabsorbed in the So the parathyroid hormone controls amount of calcium reabsorbed in the late distal tubule and the early collecting duct. So the renal excretion of calcium is approximately 10% of the ingested calcium. So 1000 milligrams intake means 10%, 100 milligram per day will be excreted. Okay, so in that the protein bound will not be filtered, the remaining will be filtered. So filtered வந்து 99% will be absorbed. 19% of calcium will be absorbed. So அதில் 90% will be in the proximal portion, only 10% in the distal portion. So the 10% will be depending upon the calcium ion concentration. So the calcium absorbed from the intestine enters the extracellular fluid pool. So that is about 1300 milligram. And there is an exchange of calcium between the bone and the extracellular fluid. See, 500 milligram is deposited, 500 milligram is again going back to the extracellular fluid. So this is the exchange of calcium between the different tissue compartments. Next, coming to the main topic, regulation of plasma calcium level. So to maintain the normal plasma calcium level, 3 hormones are involved here: calcitriol, PTH, calcitonin. So calcitriol is nothing but the active form of vitamin D3, that is 1,25 dihydroxycholecalciferol. PTH is parathyroid hormone and calcitonin. And the 3 target organs, these hormones going to act on this organs. So intestine, bone and kidney. So this picture shows the calcium homeostasis. See, there is a thyroid, parathyroid. The parathyroid is the yellow dot, 4 dots are parathyroid. So the calcitonin from the thyroid, parathyroid from the parathyroid hormone from the parathyroid gland. So they are acting on the 3 organs to maintain the calcium level. So first we will see the vitamin D, that is calcitriol. So how this is active form of vitamin D is formed, we will see the steps. So in the skin you have the 7-dehydrocholesterol. So this 7-dehydrocholesterol is converted into cholecalciferol by the action of the UV rays from the sun. So when the UV rays falls on the skin, this 7-dehydrocholesterol will be converted into cholecalciferol. So next, this cholecalciferol is converted into 25 hydroxycholecalciferol in the liver. 25 hydroxycholecalciferol in the liver. This is called calcidiol. So by the action of enzyme 25 hydroxylase. So cholecalciferol converted into calcidiol, that is 25 hydroxycholecalciferol in the liver by the action of enzyme 25 hydroxylase. So this step is very important. So this process a limited one. So because this 25 hydroxycholecalciferol has a feedback inhibitory effect on its own conversion reaction. So how this feedback, how it has a feedback inhibitory effect on its own conversion means, so this is very important for 2 reasons. First, so when the intake of vitamin D3, can increase many times, the concentration of vitamin D3 means cholecalciferol. So cholecalciferol, when the concentration of cholecalciferol increases many times, but the concentration of 25-hydroxycholecalciferol remains normal. So this is because of that feedback control, that feedback inhibition. So this prevents excessive formation of the active vitamin D and excessive action of the vitamin D. So it maintains the normal level of 25-hydroxycholecalciferol. So because it has own feedback inhibition. That is one reason. Second is, so this has to conserve the vitamin D in the liver. So which one? This cholecalciferol, this can be stored in the liver for future use. So when this vitamin D3, the cholecalciferol, is converted into this 25-hydroxycholecalciferol, so it persists only for a few weeks only in the body. But whereas in the cholecalciferol form, it can be stored in the liver for many months. So that is one reason. So for two reasons, this 25-hydroxycholecalciferol has its feedback inhibition. So by inhibiting its own conversion, so two important reasons. One, it will prevent the excessive action of vitamin D. Next one, so it can be stored in the liver. Which one? The cholecalciferol can be stored in the liver for future use. It can be stored for months. But once it is converted to calcidiol, that is 25-hydroxycholecalciferol, only for few weeks only it will be present in the body. So there are two reasons. Next, this 25-hydroxycholecalciferol. So you don't get confused. 25-hydroxy vitamin D is the 25-hydroxycholecalciferol. Okay, that is the calcidiol. So this will be converted into calcitriol. That is 1,25 dihydroxy vitamin D or the cholecalciferol. So in the kidney. So in the proximal tubule of the kidney, this 25-hydroxycholecalciferol is converted into 1,25 dihydroxycholecalciferol. So this is by the action of enzyme 1-alpha hydroxylase. 1-alpha hydroxylase. So this conversion is also controlled by the calcium ion concentration. So the calcium ion concentration, it controls the conversion, that is 25 to 1,25. So the formation of this 1,25 is inversely affected by the concentration of calcium. So it is inversely affected by the concentration of calcium. So this is also for two reasons. So one, if there is more calcium, the calcium itself has a slight effect in preventing the conversion, 25 to 1,25 dihydroxycholecalciferol. So next is, so one more important point I forgot to tell you. So the conversion, the 25-hydroxycholecalciferol to 1,25 dihydroxycholecalciferol, that conversion requires parathyroid hormone. So under the parathyroid hormone only this conversion occurs. So in the absence of parathyroid hormone, none of the 1,25 dihydroxycholecalciferol will be formed. Okay, so now comes how the calcium ion concentration controls the formation. So whenever the calcium is less, so the parathyroid hormone will be secreted. So the parathyroid hormone secreted, that causes the conversion reaction. So 25 to 1,25. When the calcium level is high, no parathyroid hormone will be secreted. So no conversion will occur. So once again I am repeating this, don't get confused. So in the skin there is a 7-dehydrocholesterol. So under the action of this ultraviolet rays, the sunlight, so it is converted into cholecalciferol, that is vitamin D3. So this cholecalciferol will be converted into 25-hydroxycholecalciferol in the liver under the action of enzyme 25-hydroxylase. So this 25-hydroxycholecalciferol has a feedback inhibition on its own conversion, so that it can maintain a normal active vitamin D level, and so that it can preserve some cholecalciferol in the liver for further use. So this can be stored in the liver for months. Whereas when it is converted only for a few weeks, it will be available in the body. Then this 25-hydroxycholecalciferol is converted into 1,25 dihydroxycholecalciferol in the kidney by the action of enzyme 1-alpha hydroxylase. This step requires parathyroid hormone. Okay, so clear. So this conversion also, depending upon the calcium ion concentration, occurs. So see here in the proximal tubule, the 25-hydroxycholecalciferol under the influence of 1-alpha hydroxylase is converted into 1,25 dihydroxycholecalciferol in the proximal tubule. Next, coming to the actions of vitamin D. So this vitamin D, it acts on, I told you, three organs: intestine, kidney, and bone. So what is the action of vitamin D on small intestine? So it increases calcium absorption. So the vitamin D, it increases calcium absorption by increasing TRPV channels, calbindin D, and PMCA expression. So what are these things? So what is this TRPV channel? So TRPV is trans receptor potential vanillite type channels, and calbindin D is calcium binding protein, PMCA is plasma membrane calcium ATPase. So this TRPV channels, they are calcium channels. It will allow the calcium to enter inside the cell. Calbindin D is a calcium binding protein, so it will bind calcium and it will transport the calcium inside the cell. PMCA means plasma membrane calcium ATPase, so that is also an calcium transporter. So it transports calcium out of the cell, so it maintains low intracellular calcium. So vitamin D, it increases calcium absorption in the intestine. So how it increases calcium absorption? By increasing the TRPV channel, calbindin D and PMC expression, and it marginally increases phosphate absorption. So this is the action of vitamin D on intestine, small intestine. So this TRPV, you have two types, V6 and V5. So this TRPV V5 will be predominantly present in the kidney tubules, whereas the V6 type, it present both in intestine as well as in the kidney. So coming to the action of vitamin D on kidney. So vitamin D also increases calcium and phosphate reabsorption by epithelial cells of renal tubule. So it increases the calcium and phosphate reabsorption by the renal tubules. So through that, it decreases the excretion of these substances in the urine. So calcium and phosphate. But however, this is a weak effect. So this role of vitamin D on renal tubules is a weak effect, and probably it's not a major important in regulating the extracellular fluid concentration of the calcium. So this is, since it's a weak effect, so not of much importance in regulating the ECF fluid calcium concentration. So vitamin D, but its role is to increase calcium and phosphate reabsorption by epithelial cells, decrease the excretion of the substance. See in this picture, so kidney, I told you the TRPV5 is present in the renal tubule. So here, that too in the distal tubule. See, TRPV5 present in the distal tubule. So through that, calcium is entering. So by the action of the vitamin D3, see, calbindin, it's bind the calcium. The distal tubule picture. See the distal tubule picture. So this is more clear. So TRPV5, distal canal tubule. So calcium is entering through that channel. So the calbindin, calcium binding protein. So it's carrying the calcium. So V5 and V6. So this V5 will be present. So V5 will be present predominantly in the renal tubule. So V6 both in intestine, renal tubule. So see, first picture you have V6 and second picture V5. So both in the renal tubules. So that's transporting the calcium. So see, see the first picture, the 1,25 dihydroxycholecalciferol. So 3 arrows, TRPV6. So that acting on that, calbindin, calcium binding protein, and PMCA, plasma membrane calcium ATPase. So that one, it pushing the calcium out to maintain low intracellular calcium, and so that calcium is entering from the lumen into the cell through TRPV6. So vitamin D, it increases TRPV channel, calbindin protein, and PMCA expression. So through that, it helps in the absorption of calcium from intestine. And this is renal tubule. So renal tubule also helps in the absorption of the calcium. So filtered calcium will be absorbed through the renal tubules. So intestinal absorption nadakudhu, then in the renal tubules the calcium is absorbed. Coming to the action of vitamin D on bone. It sensitizes the osteoblast to the parathyroid hormone. increases the synthetic activity of osteoblast. So it acts on the osteoblasts that have receptors for vitamin D. So it increases the synthetic activity of osteoblast. So it also necessary for normal mineralization of the bone, which one vitamin D. It also stimulates bone resorption. So but not directly by increase the osteoclastic activity, but by stimulating various paracrine signals that originate from the osteoblast. So through that it activates the osteoclast. So osteoclast activity is indirect one. So it directly act on the osteoblast and increase the synthetic activity of osteoblast, so cause bone mineralization of bone. It also stimulates bone resorption. But that resorption that activity is not direct one. By stimulating various paracrine signals that originate from the osteoblast, through that it increases the osteoclastic activity. So it also promotes development of osteoclast from the precursor cells. So it also promotes development of osteoclast from the precursor cells. It also increases osteocytic osteolysis. So both it causing osteolysis as well as mineralization of bone. So but finally vitamin D increases calcium and phosphate absorption from intestine, resorption from the kidney, okay, and it increases the plasma level of calcium and phosphate that increases bone mineralization. Okay, so this is a ultimate final thing. So increases calcium and phosphate absorption from intestine, calcium reabsorption from the kidney. It increases the calcium and phosphate level in the plasma and increases bone mineralization. Okay, so this is to summarize the vitamin D. So from the diet also the vitamin D3 are getting, that is the cholecalciferol, and from the sun it acting on the ultraviolet rays acting on the skin. So 70 hydrocholesterol is converted into cholecalciferol. So that one converted into 25 hydroxy cholecalciferol in the liver. Then 25 hydroxy cholecalciferol is converted into 1,25 dihydroxy cholecalciferol, that is calcitriol, under the control of PTH. So this calcitriol, active form of vitamin D3, that is 1,25 dihydroxy cholecalciferol. It acts on the three organs, target organs, bone, kidney and intestine. So in the intestine it increases calcium and phosphate absorption. In the kidney it decreases their excretion, so that it causes its reabsorption. Then in bone it causes bone mineralization. Coming to the parathyroid gland. So why we are talking about parathyroid gland here? Which hormone is secreted from parathyroid gland? Yes, it's a parathormone. So we are talking about the parathyroid gland. So there are 4 parathyroid glands present in the neck. Okay. So in the upper pole and the lower pole of the thyroid gland, are you able to see that picture? The 4 dots, those are the parathyroid gland. Yellow one is the thyroid and the 4 dots are the parathyroid gland. So the parathyroid gland, you have 2 types of cells, chief cell and occipital cells. The chief cells are the predominant cells in the parathyroid gland and are present throughout our life. Which one? The chief cells. The chief cells only secretes the parathyroid hormone. And the occipital cells, they are absent in young humans. The occipital cells are modified or depleted chief cells that no longer secrete any hormones. So here important is chief cell that secretes parathyroid hormone. See this picture? The thyroid gland, here it is nicely seen, are the 4 dots that are parathyroid gland. So in the parathyroid gland you have the chief cells and the occipital cells. Okay, so chief cells only secretes the parathyroid hormone. So parathyroid hormone provides a powerful mechanism for controlling the extracellular calcium and phosphate concentration. So it's a powerful mechanism for controlling the calcium level. So by how it is controlling the calcium level? So through intestinal reabsorption, renal excretion and exchange of calcium between the extracellular fluid and the bone. Exchange of calcium between the extracellular fluid and the bone. So through these 3 ways it controls the extracellular calcium level. So coming to calcium sensing receptors. What are the calcium sensing receptors? So calcium sensing receptors, so recently the receptor for sensing the calcium have been identified. So that is called calcium sensing receptor, CASR. So in the parathyroid gland, so the extracellular fluid calcium concentration is sensed by the parathyroid chief cells through these calcium sensing receptors. So this calcium sensing receptors will sense the extracellular fluid calcium level. So whenever there is increase in the extracellular calcium, so that calcium will go and binds to the calcium sensing receptors and activates the signaling pathway. So that will decrease the PTH secretion, parathyroid hormone secretion. So what is a major stimulus for PTH secretion? The major stimulus for PTH secretion is the calcium level. So when the calcium level is low, the parathyroid hormone will be secreted. When the calcium level is high, the parathyroid hormone secretion will be decreased. So see in this picture, there are two pictures. One is extracellular fluid low calcium, other one is high calcium. Okay, so what happens whenever there is a high calcium? High calcium na, it will decrease the parathyroid hormone secretion. So how would decrease the parathyroid hormone secretion? So I told you this calcium sensing receptor. See the calcium sensing receptors. Okay, so that are G protein coupled receptors. They are G protein coupled receptors. They are attached to phospholipase C. They are attached to phospholipase C. So whenever there is high calcium, this calcium will go and binds with the receptors. It generates inosyl triphosphate. See IP3. High calcium, see the second picture, IP3. Inosyl triphosphate and diacyl glycerol. This IP3 inosyl triphosphate and diacyl glycerol release calcium from cytostolic stores. So see there is a release of calcium inside the cytoplasm, and this activates protein kinase C and then inhibits the PTH secretion. So there is no fusion of vesicles containing the PTH, and there is no release of the parathyroid hormone. So when the calcium is high, the G protein coupled receptors, calcium sensing receptors attached to phospholipase C. So when the calcium binds, it generates inosyl triphosphate and diacyl glycerol. So this causes release of calcium inside the cytoplasm from the cytosolic stores and activates protein kinase C that inhibit PTH secretion. And so there is no release of parathyroid hormone. So this happens when there is a high calcium. What happens when there is a low calcium? So parathyroid hormones should be released when there is a low calcium. So when there is a low calcium, so the G protein that gets activated. So this GS protein gets activated. So that result in increased cyclic AMP formation. See the picture, the cyclic AMP formation, low calcium picture. Cyclic AMP formation. So this cyclic AMP activates protein kinase A, that is PKA, and that causes release of parathyroid hormone. So low calcium na parathyroid hormone will be released. High calcium na there is no release of parathyroid hormone. Coming to the actions of parathyroid hormone. So what is the action of parathyroid hormone on bone? So the PTH receptors on osteoblast, initial bone formation. So this is a direct action. Later on, bone resorption. This is an indirect action via the cytokines from osteoblast. So overall, promote bone resorption and increase calcium concentration. So what is this? So the parathyroid hormone, it activates both bone synthesis and resorption. So both bone synthesis also occurs, resorption also occurs, but the net effect is there's increased bone resorption and excess mobilization of calcium and phosphate from bones into the plasma. Okay, so finally, ultimately, it will cause bone resorption and increases the calcium level in the plasma. First, initially, it causes bone synthesis. So the osteoblast, they have PTH receptors. So the PTH directly act on the osteoblast and cause the bone synthesis. Whereas the PTH do not have receptors on the osteoclast. So osteoclasts are for bone resorption. So how it is acting on the osteoclast? So the osteoclasts do not have receptors for PTH. So what to do? The PTH, it binds to osteoblast. So the binding stimulates the osteoblast to increase the expression of rank L and inhibit the secretion of osteoprotogerin. See this picture, it will be seen clearly. See the osteoblast having the receptors for PTH, the first round circle. So the PTH binds to osteoblast. This osteoblast, what will do? It increase the expression of rank L. See rank L. Okay, increase the expression of rank L. And if you see the red rounds are the osteoclast precursors. They have the rank receptors. So when the PTH binds with the osteoblast, it increases the expression of the rank L and decrease the expression of the osteoprotogrin. So osteoprotogrin, what it will do? It will inhibit the binding of the rank L to rank receptors. Osteoprotogrin, see, it's going and binding with the rank L, so that it prevents the binding of the rank L to rank receptors. So this will be inhibited. So it decreases the osteoprotogrin and increase the expression of rank L, so that the rank L will go and bind with the rank receptors present in the osteoclast precursors. So the binding of rank L to the rank stimulates the osteoclast precursors to fuse, forming new osteoclast, which ultimately enhance the bone resorption. Okay, so since the osteoclasts do not have the PTH receptors, the osteoblast, it increases the expression of the rank L and inhibit the secretion of osteoprotogrin. So the binding of, so no osteoprotogrin, so the rank L will go and bind with the rank receptors. So this stimulates the osteocyte precursors to fuse. They fuse to form the new osteoclast, so that will help in the bone resorption. So this is the effect of PTH on bone. So it activates both bone synthesis and resorption, but the net effect is it causes increased bone resorption and mobilize more calcium from the bone into the plasma. So PTH, bone resorption, increase the calcium in the extracellular fluid. So what is the effect of parathyroid hormone on the kidney? So it increases calcium reabsorption, it decreases phosphate reabsorption, stimulation of 1,25 dihydroxycholecalciferol formation. So this step we know. In the vitamin D itself we have seen. So that 25 hydroxycholecalciferol is converted into 1,25 dihydroxycholecalciferol in the proximal tubule of the kidney under the presence of parathyroid hormone. If there is no PTH, none of the active vitamin D will be formed. So this is the three things that happening in the kidney. So parathyroid hormone action on kidney. So it stimulates the 1-alpha hydroxylase activity, so that the active vitamin D3 is formed, calcitriol is formed. So it stimulates the calcium reabsorption mainly in the late distal tubule and collecting tubule and thick ascending loop family. So that is lesser extent, mainly in the late distal tubule and collecting tubule. You remember that the 10%, so 90% of the calcium will be reabsorbed in the proximal tubule, and 10% of you think of the exchange of calcium between the different compartments. You've seen, no? So in that 90% will be absorbed in the proximal portion of the kidney. Remaining 10% is absorbed in the late distal tubule and the collecting duct. That is mainly depend upon the calcium concentration. So this is controlled by the parathyroid hormone. We already seen. So the parathyroid hormone, it stimulates the calcium absorption mainly the late distal tubule and the collecting tubules. It inhibits the phosphate reabsorption by the proximal nephron. So it represses the sodium phosphate 2A expression, that is a transporter, sodium phosphate transporter. It decreases the expression of this transporter. Yes. So action on kidney. So proximal tubule, distal tubule. See, proximal tubule, the parathyroid hormone, it decreases sodium phosphate absorption, decreases the sodium phosphate absorption in the proximal tubule. And see, in the distal tubule, it increases the calcium absorption in the distal tubule. Next, what is the action of the parathyroid hormone on small intestine? So it stimulates the calcium absorption via activation of vitamin D. So through the formation of the active vitamin D, it helps in the absorption of calcium from the intestine. So you know that it stimulates the 1-alpha hydroxylase enzyme, so that active form of vitamin D3 is formed, 1,25 dihydroxycholecalciferol. So that stimulates intestinal calcium absorption. So this is indirectly, it stimulates the calcium absorption via the activation of vitamin D. So parathyroid hormone, what is the action on bone, action on kidney, what is action on intestine? So what is the primary stimulus for the parathyroid hormone release? A decrease in the calcium level. So when the calcium decreases, the parathyroid hormone is released. So the kidney, it decreases calcium excretion, increases the phosphate excretion. That means increases calcium absorption and decrease the phosphate reabsorption. And in the small intestine, indirectly via activation of vitamin D, it causes calcium reabsorption. In the bone, it The net effect is to mobilize more calcium and phosphate into the plasma. Coming to the calcitonin, the third hormone. So vitamin D we have seen, parathyroid hormone we have seen, then last hormone is calcitonin. So this calcitonin is secreted by the thyroid gland, mainly by the parafollicular cells or the C cells of the thyroid gland. These cells are present in the interstitial fluid between the follicles of thyroid gland. The parafollicular cells, they are lying in the interstitial fluid between the follicles of thyroid gland. So they are peptide hormones. So what is the main role of the calcitonin? They tend to decrease the plasma calcium level concentration. So its role is exactly opposite to that of the parathyroid hormone. Parathyroid hormone function is to increase the calcium level, whereas the calcitonin role is to decrease the plasma calcium level. So you know that what is a primary stimulus for calcitonin? So increased plasma calcium level is the primary stimulus for the calcitonin secretions. So what is its role? It decreases the calcium plasma concentration. So the immediate effect of the calcitonin is to decrease the absorptive activity of osteoclast. The immediate effect is to decrease. How it decreases the plasma calcium level? By decreasing the absorptive activities of the osteoclast, so that no calcium will be mobilized from the bone to the plasma. Then prolonged effect is to decrease the formation of new osteoclast. So immediate effect it will decrease the activities of osteoclast. Prolonged effect is to decrease the formation of new osteoclast, and it has only, so this calcitonin has only minor effect on calcium handling in the kidney tubules and the intestine. So this is because of this it is of less importance and over the kidney and the intestine. And you know the opposite effect is opposite to that of the parathyroid hormone. So the main role of calcitonin is to decrease the plasma calcium level. So the primary stimulus for calcitonin is increased plasma calcium. This calcitonin has a weak effect on the plasma calcium concentration in the adult human. But for children, it is very important because the bone remodeling occurs rapidly in children. So in adult, it has weak effect, whereas in children, so it has much greater effect because the bone remodeling occurs rapidly in children. And there is a disease called Paget's disease, where the osteoclastic activity is more in Paget's disease. So if there is osteoclastic activity is more, means what? The bone resorption will be more. So the calcitonin has a much more potent effect of reducing the calcium absorption, calcium reabsorption. So Paget's disease, the osteoclastic activity is more, so there is a calcium absorption from the bone. So this calcitonin reduces this calcium absorption. So calcitonin, so it is secreted from the parafollicular cells or C cells of the thyroid gland. So its action on bone, intestine and the kidney. So in the kidney and the intestine it has only little effect over the bone. So immediately it will reduce the osteoclastic activities. Prolonged action it will reduce the new osteoclast formation. Okay, so this is the action of calcitonin. Coming to the applied aspect, so you have either increased calcium or decreased calcium. So increased calcium level is called the hypercalcemia, decreased is called the hypocalcemia. So first, hypocalcemia. What are the causes for hypocalcemia? Just you know the causes: hypoparathyroidism, vitamin D deficiency, renal insufficiency, acute pancreatitis. So these are some of the causes of hypocalcemia. Okay, you should know the signs and symptoms of hypocalcemia. So there is a mnemonic: cats go numb. Cats go numb. So you remember how to remember the symptoms and signs. So cats go numb. C for convulsion, A for arrhythmias, T for tetany, S for spasm, stridor, and numbness or paresthesia in hand, feet, around mouth and lips. So if you have hypocalcemia, you will have convulsion, arrhythmia, tetany, spasm, stridor, numbness or paresthesia. So they call cats go numb. In hypocalcemia, there are two signs: Trocheus sign and Chauster's sign. So Trocheus sign of latent tetany. So Trocheus sign, so this is eliciting the corpospedal spasm. The case 2 we have seen from the starting, corpospedal spasm. So latent tetany How they will check for latent tetanina? So by eliciting the carbospedal spasm. So they will inflate the blood pressure cuff. Chowstuck sign means there is a quick contraction of ipsilateral facial muscle elicited by tapping over the facial nerve at angle of jaw. So in hypocalcemia, they will tap over the angle of jaw. There will be a ipsilateral, that same side facial muscle contraction will be there. So that is Chowstuck sign. So how they check for Troche's sign? So a blood pressure cuff is inflated to 20 mm mercury above systolic blood pressure. So the arterial blood flow to the hand is occluded for 3 to 5 minutes. So if this is done, so what happens? There is a carpospedal spasm. So carpospedal spasm means, carpopedal spasm means flexion at the wrist, flexion at the metacarpophalangeal joint, extension of interphalangeal joint, and adduction of the thumbs and fingers. So this is called carpopedal spasm. So this is the Troche's sign. And see the Chowstuck sign in hypocalcemia, tapping the angle of jaw. See, there is a same side ipsilateral facial muscle contraction. This is Chowstuck sign. Next is hypercalcemia. So what causes are hypercalcemia? Parathyroid hormone mediated primary hyperparathyroidism, familial hypocalciuric hypercalcemia, tertiary hyperparathyroidism, and cancerous conditions like multiple myeloma, bone metastasis, and calcitriol mediated milk alkali syndrome, exogenous vitamin D. So all this will causes hypercalcemia. So hypercalcemia, the signs and symptoms. In CNS, they have lethargy, depression, coma, and you have neuromuscular weakness, myopathy, and there will be hypertension, bradycardia, mainly stones, renal stones, and you have nausea, vomiting, constipation. So for hypercalcemia, they call stones, bones, groans, thrones, and psychiatric overtones. So CNS affected, it's called psychiatric overtones. So thrones means sit on throne, that is polyuria, they'll have polyuria. So throne is, it's a like porcelain toilet. So you are sitting on the throne, okay, that is polyuria. Then stones, you have the renal and biliary stones, and bone, you have the bone pain. Groans means abdominal pain, vomiting, nausea, vomiting, and psychiatric overtones is depression, coma, anxiety. So CNS is affected, psychiatric moans. So renal, that is stone, GIT have the groans, and bones you have the bone pains. So summary, the calcium is crucial for the body physiological function. So it must be tightly regulated to maintain the physiological stability by the interaction between the major organs and hormones. You know, the 3 major organs and the 3 major hormones that are involved in maintaining the normal calcium level. A decrease in the calcium level, summary, decrease in the calcium level stimulates the parathyroid hormone. So increase bone resorption, increase calcium reabsorption from the kidney, decrease phosphate reabsorption from kidney, and increase calcium uptake from GIT. Vitamin D, the same effect, but increases phosphate reabsorption from the kidney. And calcium imbalance must be recognized and treated early to prevent any catastrophe. Thank you.